And so that's part of the care conference, is who is your support and how supportive is your support? And you find a range. And you know what? It's important not to be judgy. It's very important not to be judgy, because different family members have different capability to cope. And this is Lorna's expertise. And this is why I go to her many times for faculty and students that are having trouble. People exhibit coping differently. You may have had a son or daughter that said, you know what, I'm out of here. I'll call you. I'll call you and make sure you're doing okay. You might have had sons and daughters who want to be there with you all the time, that sometimes smother you. People cope different ways, and it's important not to be judgy about that, because people's coping skills are very, very different. And so we work with them. Go ahead.
These are very soft skills. Are these skills that you teach in the nursing? Let's see. You just said that the case manager is about what happens in the hospital, but the social worker is this kind of skill where you can give lessons in how to talk to people, how not to be judgmental, how to do all of those things. Is that in a class that is offered to nurses?
Absolutely. So glad you asked, and Lorna can help me with this.
Okay.
The important thing for you to understand is that who coordinates all this? It's the nurse. The nurse figures out, you know what, there's a family member who's not doing well. I need the social worker. Could you please come meet with this family? Could you have a family conference with these people? The nurse coordinates the care conference based on what she sees hour after hour after hour. And yes, we have started to understand that we need to pay attention to this. Not only the distress of the patient, but distress of the family. How many of you were worried about your family members while you were sick? I know a lot of people do. Well, that's not helping you. That's not helping you heal if you're worried about how other people are coping with your illness. So we need to think about all that stuff. And it is a very soft skill. I love the way you put that. But it makes a huge difference to how you're going to heal and how you're going to go home and transition and be well as you can be. So Lorna, help me talk about how we teach this.
One thing, Jessica, I never received your slides, so check your email. So you know what's interesting with the soft skill, right? Soft skills are now, it's evolving, and people are beginning to write about the fact that it's no longer should be called soft skills. These are the primary skills that everyone needs to learn, right? So yes, we have, it's introduced in all courses, because remember I mentioned those nursing essentials that are our guides for teaching our students. Communication of soft skills is primary in those essentials. And so in particular in psych mental health, when they take that course, that's where the communication, the practice of soft skills and the understanding of, because guess what? The majority of our patients, when I would teach mental health to students, you have to understand that it's on a continuum. Some people are here, and depending on what's happening in your life, you can move in any direction on that continuum, right? And so those what we're calling now important skills, not soft skills, are primary to who nurses are and what they do. And there was a survey done, and it's done periodically, and you've probably all heard about it, where nurses come out every single time the survey is done, having been called the one healthcare team member that makes the most difference in someone's lives. Because most nurses who, like Jessica said, nursing is a calling. And when it's a calling, people want to make a difference in the lives of those they're called to work with. And those skills are most important. And our students tend, I say tend because not all, but tend to have those kind of innately and naturally. And we enhance those with the training. Yes, Laura.
I've got another question. Actually, I was going to ask Lorraine to weigh in a little on my question. Hi, Lorraine. Nothing like being put on the spot. So if we are going to be able to have nurses have primary skills of kind of in the care psychoanalytical analysis region, is what kind of preparation would you think needs to happen if they're going to go into the home and look at the family conferences, and how can they make peace in there without assigning them all psychotherapy?
Well, you know what? Psychosocial aspect is built into nursing and has been from Florence Nightingale's days, right? So that's a part of what we pride ourselves in, knowing that when our students do a care plan in any course, that's part of the basic skill and foundation of what we teach. And every single course has an aspect of it. Psych mental health focuses on it more, but every care plan that every student ever has to do in every course has a psychosocial item that they have to address, that they have to speak to for every patient and their family, right? So so I think it's hard maybe to understand, but if it's not a course or a program you've been through, but in nursing, that's a part of everything that we teach. So it's already in our curriculum. We're wanting to enhance it to make sure then that it's not just the psychosocial part that they put on their care plan, but it's integrated in every concept we teach. And that's the difference. It's been incorporated into our curriculum for years and years and years, but now we're going to incorporate it into every concept to make it, to be more intentional about teaching it. So I think that's why nurses always get a great review. Every book, every article you read talks about the nurse making such a difference and being the #1 choice of the best care provider on the team.
You know, your question was really a great question, Laura, because yes, it is basic to our nursing. We teach it, but we all know that when you're a brand new nurse, you often miss the soft parts of what's going on around you because you're so focused on tasks and just making sure that you got the thermometer in the right direction and making sure that the IV is running. So what we teach our nurses, there's a couple things. One is they're going to be lifelong learners. You can no longer just be a go to nursing school for 1 or 2 years. We know that you can't do that anymore. And that's why Lorna was saying there's a higher level that we're teaching nurses. What we teach basic nurses is that keep your eyes open. And when something doesn't ring true to you, go to a resource, ask your charge nurse, ask your nurse manager. There are people that you can call. You can call the social worker. You can meet her outside the hall and say, you know what? Something doesn't look right to me. Could you come look? That's sometimes all you need to trigger. But for people to be open and to observe, that's what we're teaching them, because it does take some time. I can't make nurses me. I've had 40 years of experience. But the newer nurses need to be open, and they need to be aware, and they need to trust their instincts. And we're trying to teach them that kind of thing, especially in the Bachelor of Science. One of our faculty is so fabulous about teaching nurses their voice, to be an advocate and to not be afraid to use their voice to speak when they think something's wrong. The old days of, you know, nurses hiding behind the doctors and, oh, I didn't want to say anything. That needs to be gone, and it needs to be gone forever, because we need people to speak up and to advocate. And that's part of what we're teaching in our basic nursing programs, is to use your voice, trust your instincts, be aware. Does that help? Did that kind of answer your question?
And I just want to add what Jessica said, something really important. And I think it's important to understand that new nurses, it's like learning to ride a bike. How do you make sure the handlebars are going straight while you're pedaling? There's so many different things that they have to figure out. And so but I will say this, new nurses are so scared and they're trying to figure it out, but they tend to understand the heart. They chose nursing because they cared about people. So their caring helps them see, observe, and recognize some of those. They may not know what to do, but we teach them, like Jessica said, to go to someone who's above you, go to someone else and say, I noticed this, I don't know what to do, please help me. And that's the trigger. So they're learning, and we tell them it's going to take you at least 2 years to figure out which way to hold the handlebars, how to make sure they're going straight, how to keep yourself upright and pedal all at the same time. And that's what they're expected to do those first years. And that's not easy. I watched my little granddaughters last Sunday trying to learn to ride their bikes without training wheels. And it's, you get the hang of it, but we do. And I think it's important that nursing students recognize your nursing instinct. We've taught you a lot. You may not remember everything, but something always tells you when something's not right, and to go to someone else with that. Jessica, tell me when you want me to show your slides. I have them.
Can I interrupt for just
Sure.
a second? I'm not sure that you are totally aware of Mended Hearts and the fact that 5 of the people who are on the video today are all accredited visitors. We have other accredited visitors. And then we visit where we were able to get into SMC on the 8th floor. And so for those of us like myself, I'm also the visiting chair for our chapter. We have, of course, a tremendous amount of interplay, particularly with the day shift of the hospital. And for us, for me, I've been visiting now for about 9-10 years. I have seen a change among the younger nurses. Obviously, the nurses, like the charge nurses and everything else, they've been there a long time, so the change isn't as great. But so it is pretty important, which makes me also make an offer: is if you ever would have thought that it would be worthwhile to have somebody from Mended Hearts to speak to nursing students, we would be, I'm sure, between Susan, who's our president, she's also a visitor, Laura's a visitor, myself, I'm sure we could put together a little 15-20 minute program.
And we will take you up on that. I'm going to tell our faculty to reach out, and they will be delighted to have you.
We have the time right now because we can't visit at the hospital.
Great commercial. I love that, Bill. Thank you. Well, and if you guys don't mind, we lost a little of our recording. So if you don't mind us spending just a few more minutes to answer some questions and things, because we really want to have your wonderful information as part of what we have on our YouTube channel for everyone to look at. So in fact, I just happen to have another question. You mentioned the Sutter Care at Home program. Could you tell us how long does that last for the patient? Is that 1 week paid for, 2 weeks paid for?
It depends what the needs are. My husband had got very, very sick and had to have an IV line put in his arm and had to go home with that. And Sutter Care at Home came for over a month to provide care every week, to change the bandage. Even though I'm a nurse, they came every single week to do the care so that I wouldn't have to be the primary caregiver. It really depends on what your needs are. And again, it's our responsibility to help you find out how you're going to pay for that, whether your insurance pays for it. That's part of what the case management team is about. You should not be sent home without resources and having that assurance and confidence that you're going to be okay at home. So Sutter Care at Home is made up of nurses, physical therapists, case management. There's all those different disciplines that go to the home and figure out what you need. Because sometimes when the nurse first visits, She gets to the home and she didn't realize that you had stairs. She didn't realize that you're sharing a bedroom with someone else. She may not realize that you're sleeping on the couch. Not all families have these resources. You know, there are a lot of combined families. And so that's why she has to be able, that nurse, he or she needs to be able to call on other disciplines to come in and say, you know what, this person can't heal sleeping on the sofa. This person needs a bed at home. This person needs, you know, a curtain or something to give her some privacy. We can supply all that stuff for you.
And set up to have a hospital bed put in the living room or something like that.
Exactly.
Yeah, I've seen
And
that.
some privacy. We can arrange to have those screens, those wonderful hospital screens. But you know what? If it gives that person some privacy and it makes them feel better, that's important. Because Lorna's told you, if you're depressed, if you feel hopeless, it changes the way your body reacts. And the healing process, the actual knitting together of skin, doesn't happen. We now know that your wound can actually refuse to heal if you don't have nutrition and a good attitude. If you're depressed, it actually impacts the way your body reacts to healing. How cool is
Laura,
that?
yeah, Laura, I don't know what your experience was, but 14 years ago, and my surgery was at Summit, I had a home nurse come. In this particular case, I had her come once because my situation, fortunately, was just fine. All of it was fine. And I thought somebody else can use that resource better than what mine is. But some of what was going on was 14 years ago. And it dawned on me after I became a visitor and watched the caseworkers and social workers up on the 8th floor, it dawned on me that the questions I was sort of being asked by the nurse of, is there somebody at home? How many stairs do you have? Especially, you know, is there someone at home to take care of you? How are you going to get home? I didn't, in my drug state, I gave them answers. I gave them truth, but I didn't realize how important those questions really were at the time. Laura, the other thing you said, and I've got to call you on this, is you said, you know, do people come when you're not drugged up? For a lot of us in the hospital, I not only was on pain meds in the hospital, I was on them for another 2 weeks afterwards. I don't know how many people go home off the pain meds, especially if they've had, you know, what I call the big sled, the true open heart surgery. Let me tell you, you know, if you've had the bypass, you're not going home without the pain meds.
Right. Susan, I have a question for you.
Sure.
Because this is an area that's really important to me. And you said they asked the questions, but you didn't really think of the seriousness and how important. What do you think would help what can nurses do to help the patient or the client understand and I think I know, you know, explaining this is why. And I think when I've taught students, I recognize the importance is to explain to them why I'm asking them questions, why I'm doing certain things, even in the classroom. So I'm wondering if maybe we need to make sure we teach our nurses, our nursing students in particular. Sometimes, of course, most times, 100, maybe 90% of the time, patients aren't going to understand why this is so important. Your patient teaching needs to include why, right? So would that help, or what else could you think of that might help that we can teach students that would help you?
I'm a retired teacher, so I agree with you a lot. I also have to quickly just say, when you're talking about brand new nurses and how it takes them a couple of years to be able to integrate all that they really need to do, basic classroom teaching is exactly the same. You get real teaching third year when they're in their third year. I couldn't believe it. That's exactly the way it is in like public school education. That's the way it is. You're inundated with all these things, and it takes a while. But I think you're right. You know, if someone had actually said to me, gee, we're asking you this because. Now, the defense of the hospital, number one, this was over 14 years ago. So things were a little different. And number two was this happened between the week between Christmas and New Year's. So a lot of the regular people weren't there. For obvious reasons. I got great care. I have no complaints about the care I got. I have no complaints about any of it. And I was a scheduled surgery. I wasn't even an emergency. But you're right. I think with explanations, and it can be real quick, you know, it's just, we're concerned about how many stairs you have to climb to get into your house. That kind of thing.
Could I make a suggestion on this also? If and when possible, I know this happened in my case. My surgery, I lived in another state at the time I had my quadruple bypass. I think the reason that I didn't obviously went home with somewhat drugged up. I didn't probably remember 90% of what they said, but at least I had somebody else, in this case, my wife, who was there when they were giving a lot of the instructions, in particular working with the case manager and else. And if and when it's possible, because not all patients have somebody else who can be there, that is the time to their best, if they could schedule it or request that somebody else is there, because they'll hear it and they'll remember it.
And it's interesting because, and Susan, I hear you. However, Jessica and I have been in nursing for 30, 40 plus years. And I know for a fact, patient teaching was huge when I was a student and huge for me on the unit, because so I try in the classroom to instill in students ways that help them understand. And even, you know, the new dean at Samuel Merritt, I sit in meetings with people and they're calling out all these letters of all these groups and organizations. And I'm like, whoa, you're not even speaking a language and I'm in healthcare. Can you explain this to me? So we have to understand, students need to understand that you're explaining something to someone and it's a different language. I have a friend, a very close friend, who fell on the Great Wall of China, had to have surgery on her leg and she finally got it. She's laying there, a nurse in the bed, and people are speaking other languages around her and she's having surgery. She doesn't know what's being said to her. And I said, now you get to see what it feels like, patient in the bed, nurses, doctors trying to explain things to them. And they say they're using lay language, but give me a break. It isn't usually. And so it's really helpful to hear this, because I'm also working on developing our faculty, Susan, because one of my biggest soapboxes is we take these wonderful nurses from the bedside, we bring them over to the academic side, we throw them in the classroom, and not everyone realizes the value and how vital it is to teach someone how to become a faculty and a facilitator of learning. It's very different than being at the bedside, right?
It absolutely is. Yeah, teaching, being able to teach by itself is an art and a science, and it's a real skill. And it's, you know, everybody thinks they can be a teacher, however, not reality.
No, and it really is about connecting the dots, not just giving definitions and concepts, but how do you connect the dots for students? So the connecting of the dot is you have someone who's on pain medicine, they're not able to focus and concentrate. So how are you going to teach? And who might you teach if they can't hear you? And that's the part that I'm trying to teach the faculty how to do, right? So we're doing a lot of faculty development.
I know what Bill just said was, as a Mended Hearts visitor, oftentimes, you know, if I'm just seeing a patient in the room that is on their meds, they'll nod at me, they're nice. I leave them the information. I don't think they've absorbed any of it. But if there's someone in the room with them, whether it's a, you know, whatever kind of caregiver it is, family, friend, whomever, those people are usually pretty receptive to what we have to say.
Very true. Very true.
They pay attention, they ask questions. they pick up our booklet and start going through it. Because, again, their head's a lot clearer. But again, if the case managers or social workers or something really need to communicate something, oftentimes it's the caregivers that you can work through. They might actually pay attention.
Okay, Laura,
Yeah, yes.
how are we doing?
Well, I think that that certainly, where am I here? There I am. I think that that does get a chance to cover some of the things that we lost in our recording, and certainly gives people who couldn't be here today a chance to hear some great information from both Dr. Kendrick and Dr. Eads. So I'm happy. Any other questions? Steve, I see you. Julie, you. Any special questions, Paul?
No special. This is my first meeting, so it was great to listen. A phenomenal amount of information. I just got out on Tuesday from Eisenhower Medical after my aortic valve placement. So
congratulations.
thank you. And I'm pretty mobile. I'm in a resort nearby. It's all well and good. Super hot down here. But I did want to say, it might be interesting to the group. This is my second time having remote cardiac care. I spent a week in a hospital in Rome back in 2016. I had 2 stents put in, and I speak enough Italian to, as I say, get into trouble, but not out of it. And in that hospital setting, most of the people there spoke little, if any, English, including the doctors. And so between English, Italian, sign language, and a lot of telepathy, we made it happen. The doctor who did the stents, she was great. She had been trained in the US. But it's quite an experience. And I had some very, very funny times. In the end, it all worked out well. So I can certainly sympathize with what it means to be at the bedside trying to communicate with somebody who you may not think can understand what you're saying. Half the time the nurses would look at me and be like, do you understand anything I'm saying? Right. And I just look at them and said, smile and hope that was a good enough answer. So awesome session. So thank you very much for including me.
Thanks for joining. I agree. This is Julie, and I just wanted to say that I was like Susan after I had my valve repair. The nurses came in and said stuff. I didn't remember half of it. Fortunately, my husband was there, and so he, made a mental note of everything. Because when you're taking those medications, you are not really there. So, and you're tired. You can't hardly keep your eyes open. Yeah, so I think that's really an important thing, training the person that's there to help you in the future, because you're not going to remember any of that stuff. So thanks.
Yeah, along that line, Paul, one of our visitors, George Collier, who isn't here today, he had his first heart attack when he and his wife were on a trip to Italy, and he was in the hospital for about 2 weeks. And he said that he related the same story you did, the difficulty when, he had he and his wife are very fluent in Spanish, and so therefore they could make out some of it. But he was saying what a difference it made when he had his unfortunate second heart attack. At least here he was back in the States, and he went into Summit Medical Center, and being able to talk and understand exactly what was being said. So
Yep. It adds an extra special flavor to the adventure. But for anybody who's curious, of course, I'm an American citizen. Everything was free. There was $0 or euros charged at any point. In fact, when I left after 5 days, I was staying with friends in Rome, and I sort of laughed about, hope they don't track me down with that bill. And they said, well, there is no bill. It doesn't work that way. The hospital is endowed with a certain amount of resource to deploy throughout the year, people, money, supplies, and you happen to be here in May, and so you got right in the thick of it. He said, so there is no bill, so don't worry about it. And indeed, there is no bill.
That's true. A friend of mine, we were all on a cruise, and she ended up in the hospital on the Isle of Patmos, right? Not one bill, and they had to fly the family back to the States.
Wow.
And the last thing I'll say is that after I got discharged, I went to the Farmacia. I went to the pharmacy with my prescriptions. I had 6 things I needed, 1 month supply of each, which here at home would cost what? It could be $200-300 easily, or if not more. And so I gave the pharmacist my list, and she came back. She said that'll be 18 euros. And I said, I want to make sure I heard it right. I said 18 euros for 6 meds for a month. She said yes. And I said, why in the world is it so cheap? She said, what do you mean cheap? The government sets the prices.
Huh. Let's get to Catherine. Catherine, go.
Now, Catherine, unmute yourself.
Catherine, can you unmute yourself? Catherine, you have to go down in the bottom left.
I've got it.
Okay.
Okay. I think Mended Hearts should applaud yourselves. After I had my TAVR, one of you came in with a booklet or whatever, and I thought, oh, that's nice, pleasant, or whatever, you know. And I had not one intention of doing whatever you suggested, but my daughter was in the room, and she said, "Mom," so. In result, I went up to Alta Bates to the cardiac rehab for 40 substations. Best thing I've ever done. So, but it's your booklet, it's your suggestion. It came from you, the Mended Hearts group, as how it got started.
That's great. Thank you, Catherine.
I will take credit for that because I'm the one, they do the TAVRs on Thursday and I'm the Friday visitor. That's how I can.
Thank you. I remember you were pleasant, but so was I. I hope.
Oh, absolutely. Oh, no, I would have remembered. I've had very few unpleasant people. And believe me, you were pleasant.
But as you say, the other person in the room is the one who picked up and carried through on the intervention.
That's great.
Mm-hmm. Thank God for my eldest daughter. She's my mother now. I'm the daughter, you know.
Yeah, that happens, doesn't it?
What wonderful stories to hear from you, Catherine, and you, Paul, and Bill, of course, and Susan. This is a great way to have some real interchange between our group as well. And thank you, Lorna and Jessica, for helping us have an atmosphere where we could just go with you and hear your experiences and your stories and what you're doing with nurses. And we could be there next week, Lorna, as far as having a or close enough.
Why don't we, if they want us to come, why don't we have them? Susan, is it okay? You're the president. If they contact you and you organize anything as far as us going to Samuel Merritt to do any sort of a program on Mended Hearts and everything?
Sure. Yeah, I'm more than willing.
Okay.
That's wonderful.
I want to thank Jessica and Lorna for what you're doing, but also for your great presentation. This was fascinating.
This was wonderful. Thank you so much. And thank you, everybody, for showing up and tuning in and giving us some great feedback and some great questions.
And thank you so much for inviting us. It was a delight to meet all of you. And believe me, we will stay in contact.
Okay, great.
Okay, perfect.
Bye-bye. Have a great weekend.